So welcome friends. Today in another episode of NTB Dialogues, this is season 2 and 90 for 90 Global Voices series. We have a very special guest today from Tanzania. Before I introduce our guest, let me please say a few words that, this special guest is not only going to speak about TB, but also about malaria, and we can probably hear his insights also on HIV, but let's see. But it's very important because governments in 2015 committed to end TB, end malaria, end AIDS, and viral hepatitis, and several other goals and targets in 2015 when they adopted the Sustainable Development Goals. Over 90 months have passed by since then. Next month, the governments will meet to review. So, and almost less than 90 months are left. We are almost at the midpoint. But have HIV, TB, malaria rates halved compared to 2020? So if you look at malaria rates, for instance, they have definitely come down if we compare with the rates from 2015 or 2020, 2000 to 2020. But the decline is not satisfactory. And same goes for tuberculosis. Actually, TB deaths have increased. 1.3 million people sadly lost their life in 2015 to TB. But as per the last global TB report, 1.5 million almost people died of TB. Every case of TB, malaria is preventable if prevention is possible, is made available and accessible to people. So let us hear, more from our guest today. He is a very special person. And also because he represents the youth community too. He's Aloyce Urassa. Welcome, Aloyce.
Thank you very much, Bobby, and I really appreciate this invitation.
Thank you. So Aloyce, friends, as many of you may be knowing, he's from Tanzania. He's a public health scientist specializing in implementation and health systems research with a background in health laboratory sciences. He's currently the chair of the African Leaders Malaria Alliance Youth Advisory Council and a board member of Rotarians Against Malaria Global, as well as a Global Fund Advocates Network GFAN speaker. He previously served as a co-chair of the SADC Youth Forum, Climate Change and Environment Committee, and country coordinator for the Next Generation Global Health Security. What a proud moment, Aloyce, to have you amongst us. Welcome.
Thank you very much.
Yeah, thank you. So Aloyce, let us dive deep into, please tell us about, is Tanzania on track? And I will leave it up to you whether you want to refer to Tanzanian context or also expand it to African. But are we on track to end TB and malaria? We are, as we know, we have just passed the midpoint actually in terms of SDGs 2015 to 2030. Have the TB, malaria rates declined satisfactorily? Over to you.
Thank you very much, Bobby, and thanks again for the warm introduction, but also for the invitation to participate in this particular interview, which comes in a very critical moment where we are heading towards high-level meetings that are going to happen in the coming month, where the global community is going to be discussing several matters at a high level, including United Nations high-level meeting on TB, but also a high-level meeting on pandemic prevention and preparedness, the PPPR, and many other discussions that are going to take place, including the SDG summit that's going to take place. But also, this is coming ahead of just 1 week ahead, whereby next week we are going to have Africa Climate Summit, which is also a very important area for discussions on the interaction of environment and health. As you know, when we come into the concept of One Health, that there's a huge interaction between human beings, environment, and the agents that cause diseases as well as animals. So coming to the context of our discussion today, malaria, HIV, and TB, and with reference to malaria, for instance, with the recent statistics that we have, that over 200 million cases have been, over the past decades, have been reported globally, malaria cases. And there's been a constant number of over 400,000 deaths each year occurring, with 2021 having the 2020 during COVID having more deaths, with a 12% increase in number of deaths, where we had over 600,000 deaths due to to malaria alone. And a large number of these, over 70% of it, is children under the age of 5 and pregnant women. And when you look at these diseases which are affecting children, then you'll see that it is a threat to our future. It is a threat to manpower. It is a threat to sustainability, as we are discussing also sustainable development goals. Coming back to the context of Tanzania, there's been, when you talk of whether we are on track or not, starting with malaria, there's been I can say, call it significant decline in terms of malaria prevalence, whereby in 2022, it was reported to be average of 8.1%, which is a decline from 2015 when there was 14 point prevalence percentage. And then, but now looking at the risk, for instance, in Tanzania, over 90% of the population lives in places with high malaria transmission or with malaria transmission. That's endemic places to malaria. So this is a disease of concern to a country like Tanzania, which is endemic. And given the current global statistics, that 4.1% of all deaths that occurred globally came from Tanzania, which is among the top 4 countries, which contributed highly to the malaria burden globally. Looking at tuberculosis, TB in Tanzania, in 2021, there was over 87,000 cases reported, and 86,000, these were, we call them new or relapsed cases, new and relapsed cases, and that is in terms of incidence, as epidemiologists will call it. And with this, there was a 2.3% increase in TB cases in the country as compared to the year 2020. And what is even more painful or more alarming to us is that for 16.2% of these new cases were of children under the age of 15 years of age. You can see how risky TB is in our country. I've not yet answered the question whether we are on track or not, but with this increase in having children affected with TB, it's a threat and does not allow us to be relaxed and say that we are somewhere or we are heading somewhere, because in 2015, the percent out of all TB cases, it was 10%. Let me not call it only, because 10% is still very big. 10% of it was children, but now there's been an increase of 6.2%, where by 2021 we had 16.2% of it being children. So this is a disease of risk of now. It is a risk of the past, risk of now, and it is highly risky for the future. Looking at the incidences, there has been a decline in terms of numbers when you talk of the statistics, that the incidence of TB between 2015 and 2021 had a 32% reduction. And in terms of death, there was a significant reduction in terms of deaths, so whereby in 2015 there were 58,000 cases reported, while in 2021 we had about 25,800 cases deaths reported. And this puts Tanzania as a country among the 3 high TB burdened countries to have passed its first milestone, one of the milestones in the NTB strategy, and makes it among the 6 high TB burdened countries which has achieved one of the targets on the fight against TB, that is 35% reduction in the deaths as of 2015. So I'm going around not to be able to answer exactly whether we're on track or not, because for me, even if it's one person dying of a disease, then we are not yet there. So until we are seeing that zero coming, until when we are able to see more regions reporting less number and closer to 0 percentages of deaths in terms of TB, in terms of HIV, in terms of malaria, then I'll be able to say, yes, we are moving. But seeing all these changes in terms of numbers, prevalence, this year coming high, this year coming low, tells a lot about lack of sustainability. And another thing, we'll talk about funding, for instance. Now, recently with all these 3 diseases, HIV, TB, and malaria, over 90% 90% of the funds comes from the donors. It sounds like a good statement to have to receive a lot of support from external sources, but it is a threat. It is when you look at at another angle, you'll see that it is not something that we should cheer up for, because we should be able to handle our own problems. And with the current budgets that we have for health, what is being allocated for health, it is still a problem. So unless we are able to allocate more than what we are seeking from outside, then I will say that we are on track. So, and the picture of Tanzania tells about Africa at large. If you look at all sub-Saharan African countries, you'll find the numbers are more or less similar. So if you go to Nigeria, if you go to Uganda, if you go to all other countries, you'll find that the numbers are almost closely there. The burden is almost similar. The gaps are almost similar. Challenges that are there. We have a lot of shared challenges and opportunities in these countries in terms of funding, in terms of treatment capacity, in terms of diagnostic capacity, in terms of follow-up and stuff. And maybe I'll talk briefly about the treatment for TB with the context of Tanzania, for instance, where the treatment strategies have identified and seen that the more you engage the community, the more you can identify more cases, and the more you can enroll more people into TB treatment. And it has showed that out of all these detected cases, both relapsed and new cases, over 90% of these cases have been treated as per the report of 2021 in Tanzania, which is the current data that I can find it public. Now, this 4%, it might sound, it's like a breakthrough, but 4% of people dying, it's a lot. When you turn it into numbers and you count it as lives of people, then you'll see how still bad the situation is. So there was unfavorable outcome out of this 4%, which is 3.3% of it. And all these were deaths. When you say unfavorable outcomes in terms of treatment, then it's mostly a death. And there was also loss to follow-up. And I keep wondering, why we acknowledge loss to follow-up? This is among the things that we need to be at a stage where we can handle, and we can handle everyone, ensuring that everyone is comfortable, everyone feels received, everyone feels covered in the system or in the healthcare system, so that we do not have to acknowledge and report loss to follow-up in terms of treating these cases. And there are also some cases which are more biological, which needs more stronger intervention or innovations in terms of treatment failure. So there's a slight percentage of people who failed, whom the treatment of TB failed. And this brings us to a discussion on drug resistance. Although Tanzania is considered a country with low mass drug resistance for TB, but still there is about a consistency of 1.2% in terms of resistance. And when we talk of 1.2, it might sound as a very small number, but this is large when you count in, you put it in the number of people. This is 442 people. So imagine having 442 people taking drugs but not being cured. Imagine these people could have worked for two big companies. Imagine a company which can employ 200 people and produce. So you see its impact in terms of economic loss, its impact in terms of family upbringing, because these people have families. These people, most of them are adults. That means they're people could be relied on in their families. So the loss is more than just deaths. The loss is more than just people being sick. There is more loss in terms of that. Thanks, and back to you, Bobby.
Thanks a lot, Aloyce, for this kind of an overview. And we totally agree with you. Like there is zero excuse for not acting upon what we know works in TB prevention, in malaria prevention, in diagnosing TB and malaria, in treating and managing it. Even one death is a death too many. We always say TB is preventable. It is not preventable for 10.6 million people worldwide who get TB in a single year, or TB is curable. TB is curable, but 1.5 million people lose their lives because of TB in a year. This is worldwide. So this is not acceptable. Absolutely. We need to walk the talk. So there's so much more which can be done. And thanks a lot for pointing on range of issues which you have, when you were, speaking earlier. Can we go a bit deeper? Like, for instance, the WHO, the World Health Organization, has endorsed and recommended that the first test which should be used for a person who has presumptive TB, who may feel that who wants to get a test for TB, the first initial test should be a molecular test, so that we can diagnose accurately, so that we can diagnose early, and so that we can also pick up rifampicin resistance, which is the treatment can be provided within an hour or the same day. This is possible. We have the technology, we have the tools. But I come from India, Aloyce, and in India, only 23% of patients, of people who had presumptive TB, they got molecular tests last year. This is not acceptable. 77% had to go for sputum microscopy, and sputum microscopy, as you know, is less sensitive, and its sensitivity even dips further when we talk of children or people living with HIV and some other populations. So just coming back, we know how to diagnose TB. We do molecular tests. We know the best of treatments: 1 month treatment for latent TB, 4-month treatment for drug-sensitive TB, 6-month treatment for drug-resistant TB. This is more effective as well. It is not just about it is not only the latest treatment, but it is also way more effective, way more shorter, way less toxic for people. So let us hear more on what kind of tests are we using in Tanzania and other African countries. Are we using the latest molecular tests, and are those tests point of care or decentralized? Or are they centralized and they need big laboratories? So back to you, because we do have point of care and decentralized tests. I think that must be a reality for everywhere, especially in countries which are low resource. Over to you.
Okay, thank you very much, Bobby, for that question. And when it comes to diagnosis, it's a very important approach when it comes to healthcare. Or if you're talking of universal health coverage and you do not have stronger diagnostic systems in place, then there is no way you're going to achieve that universal health coverage. If you're talking of achieving zero TB, zero malaria, zero HIV infections, then there is no way we are going to achieve that if there is no sufficient diagnostic capacity. And that's why continents, for instance, in Africa, there has been it has been imperative to have systems like the Africa CDC, where it is now autonomous to supervise, to build capacity for other countries, but also to build that capacity and at the continental level to ensure that there is more availability of this testing, there is more availability in terms of workforce, infrastructure, and all the important building blocks. And coming down to Tanzania and looking at the capacity of testing or diagnostic services that are available for TB, since 1968, with the support of British Medical Services those years, just post-independence, Tanzania was supposed to establish a central TB and leprosy reference laboratory as the CTRL. And this laboratory has been doing its work 4 years and with improvements, but still there are gaps which are there. And currently the laboratory is SADC accredited and has it's established under it's working under the program, a specific program for TB and leprosy, that is the National TB and Leprosy Program. Just like for malaria, where we have the National Malaria Control Program, the NMCP. So some of the tests that are being done there, it's always the common tests. One is the microscopy, whereby there's an deployment of fluorescent microscopy technique. And also there is a use of Zedian stain. Zedian stain is a technique where they're using a sort of chemicals to stain They collect the sputum, then they put on this on a slide, microscopy slide, and a microscopist goes to look at it to see if there is a presence of what we call acid-fast bacilli, and then those are the Mycobacterium tuberculosis, which causes TB. So the problem with this technique, it's a good technique that can be very specific but less sensitive. As you said, can be it's less sensitive, but it will work. It works even less better if there is a microscopist who is not an expert enough to do the work, or who has not enough experience to do the work. And most of these laboratory works need someone behind to confirm that yes, what you saw was Mycobacterium tuberculosis. What you are writing, it is what you really saw. But now, looking at the capacity of our health facilities, it is hard to find more than one microscopist in a lab. So this makes the tool not really reliable in terms of diagnosing TB. Another technique that is being used by that lab and many other laboratories that are within, we have zonal referral laboratories, reference laboratories, including the one in the northern Tanzania, where there's a Kibongoto hospital with which has been dealing with TB cases for years, since before independence. And another technique, as I was saying, is culture and the microbiological culture, whereby they use different kind of media, as Aloyce media, MGIT media, different kind of media that are being used. And sorry for the audience that this might be a bit technical jargons, but the problem with these tools now, in terms of culture, whereby they grow the sample on a media, it's like a disc or a dish where they grow the sample to see if the bacteria will grow after some days. The problem with this is in terms of time and also expertise. Again, we need experts who can do the work. We need resources which are well stored in terms of the capacity, but also to perform TB, these TB cultures and stuff, we need a laboratory that is well structured, a level 3 laboratory with level 3 biosafety cabinet, where it offers protection to both the sample but also the person who is conducting that experiment. But now, if you look at many laboratories, the capacity of doing that, they might have experts, but the facility cannot support to do it's not supportive enough to do the work. So those are still gaps that are within the system. And another issue with this, the culture, is number of days that it will take. So like in the national reference, the TB and leprosy laboratory, it takes up to 63 days to confirm a culture result. So you can imagine you are sick and you have to keep taking some drugs that are just prescribed from somebody's looking and assuming that this should be TB for 63 days. And I think this could be another reason which is taking us to resistance and drug misuse, and even leading to other problems to people, co-infections, where someone is going to be treated for TB, but also in a few years, this person is suffering from liver diseases, from kidney diseases, because of the many drugs that have been accumulated to the body of this person. Leaving the amount of time, so it will take between 49 to 63 days to culture. But with another technique being used is the DST, where they're doing drug susceptibility testing, because after you have seen that the bacteria has grown there, then this person is having the TB infection, then there's a need to test the drugs. And this will take again other 4 days. So makes it about 70 days just to say the person had TB. Perhaps the person might have already died, and that's when you are bringing the results. So you can see the inconsistency of these techniques. But the technique that now we have discussed that is of interest, that is the molecular technique. It is the most highly sensitive but also specific technique that can be used. And most of laboratories, especially the zonal laboratories, have now have the gene expert machines for TB. And this takes less days, maximum of 2 working days as a turning around time. So at least within 2 days, a person will be confirmed whether it's TB or not, so that to be enrolled to the treatment regimen. And if you look at number of people who have been diagnosed, over 99% of them were enrolled to the to treatment immediately after testing. And this is also adding to the capacity of treating and fighting TB in the country. But now this again takes us to another challenge of having latent TB cases. And a study conducted in 2021 in Tanzania showed where they used also molecular techniques to detect, which are not available in many, especially the low resource settings, where you might just test, but people only go to hospital when they feel sick. But there are these people have latent TB, whereby they will not feel sick unless they are tested for TB. So there are cases of adolescents recruited to a study, and when they are tested, some of them between 18 and 19% of them out of many studies had latent TB infection. And the study suggested and kept a recommendation that there's a need to raise awareness among adolescents also to check their health status, but also the population of those living with HIV to test their status, because having HIV is also a risk to getting TB, because HIV lowers the immunity. So if there is no this capacity of testing and ensuring that a person has tested positive for HIV or even negative for HIV has to be cancelled to go also to do TB testing. But now the capacity is the problem. Or telling a person that you're going to be tested and it will take 60 days to have your results, then why should I do that test? So there's really still a need to build that capacity to ensure that, especially the molecular technique, which is expensive in terms of cost, but I can say it is cost effective in terms of the value that it gives to, because we cannot weigh money and people's lives. So no matter how much it costs to perform a molecular diagnosis for TB, then it's a moral obligation to ensure that for the government and stakeholders to ensure that they avail enough resources to test effectively the people. Because if you are going to say you want a cost-effective technique, you want something that is cheaper, then it is risk for the people, which is going even to cause more economic burden than how much we could have spent to test and treat the people. So the government must see the importance of investing more into these molecular techniques that have proved beyond doubt that they are better than any other technique that the other conventional techniques that we have been using for diagnosing and confirming TB cases.
Yeah, absolutely. Totally agree with you, and glad to know that molecular tests are being used in Tanzania. So the test which you mentioned is semi-centralized, but it's of course like a great one. In India, the most of the molecular tests which are used to detect TB, like 23% of presumptive TB is diagnosed in India through molecular test in 2022. That's a 2022 data of the government. So all the people who get molecular tests, they get a point of care and decentralized battery operated molecular test called TrueNat. So I've heard that it's also being rolled out in Tanzania. So am I right, or have you heard about it? And because it's point of care, battery operated, decentralized, so perhaps it makes much more sense than semi-centralized ones, which like CBNAT and others. And of course, LPA needs, as you mentioned, biosafety level 3 laboratories, which or higher infrastructure, centralized laboratories. Let's say, put it this way. So you're very right. If we need to diagnose, so if the person is unable to come, then the test should reach the people, especially in low resource setting. And before you answer my question about TrueNat and if you have point of care on decentralized molecular testing in Tanzania, let me also reinforce what you just said about economic impact of tuberculosis and malaria. Like it is not about, it's not about health spending, it's health investment. It's a smart investment. But apart from that, whether it is, first of all, the thing which should take primacy is what Aloyce has just said. It's a human rights imperative to provide best of diagnostics and treatment and care and support for every person who has TB and malaria, and to prevent break the chain of transmission of the infection as well, of course. When it comes to TB. So Aloyce, you might have read a very recent report, just came out early this week, says that $1 of invested in TB will yield $46 later on. And this reminded me of a World Bank report which came up, I think, in 2007 or 8, which said that $1 invested will yield $9 in some countries and $15 in very high burden countries. So imagine, there is, of course, there is a human right imperative. There is a economic sense as well in investing in TB and malaria, and let us hope that happens. So now I should, close my mouth and let us hear from you about the rollout, if it is happening, about point of care, decentralized, battery operated, easy to use kind of molecular tests, which can be used in the settings and difficult to reach people to. Over to you, Aloyce.
Thank you very much, Bobby. I don't have enough sufficient information to answer that. I think I need to do a closer follow-up to see if that is being deployed in the semi settings, but also in the lower level settings. Yeah.
Yeah, thanks a lot. Thanks, Aloyce. Please let me know over email or WhatsApp or later on if you find more information. Also, because the TrueNat which we have in India is a multi-disease platform. So it can also test the machines which were deployed by Government of India for COVID-19. They are also being used in TB program. One of the government program officers in Kangra in Himachal Pradesh told me earlier this month. So similarly, they also test HIV, malaria, and hepatitis, HPV, and it's about 40 or 30 or 40 more such infections. So it will be, and of course, I think CBNet can do that too, probably to some extent. But you are more of a scientist than me. I'm not a scientist, so we will look forward to hearing more from you later on post this session, and we will post an update if there is any in the description. So before we close, we know we have taken a lot of your time, Aloyce. You must have so much to do. And all the best for the meeting, which is coming up next month. But before you go, please share what needs to happen in the next 90 months or whatever, or as soon as possible. Why wait till 90 months to diagnose TB as soon as possible, earliest, accurately, to put people through the treatment and cure with the best of things, and so that, and of course, break the chain of transmission of TB infection. And of course, and also in malaria, it is not acceptable that people, especially or children, are dying of TB or malaria. This is not an acceptable thing when we say these are when the governments have committed to end TB and malaria both. So back to you, Aloyce.
Okay, yeah, thank you very much, Bobby, and for that description as well. Looking at the next 90 days and looking back at what has been done within the last 90 months, sorry, not days, months, about 7.5 years since the promises that have been made in terms of ending HIV, TB, and malaria by 2030. I'm worried to say anything about whether we'll be meeting the targets by 2030, because there are targets that were made for 2023, and for instance, in terms of malaria, whereby the Commonwealth said having malaria by 2023, and then there's zero malaria 2030, and 90% reduction of different diseases by 2030, and achievement of the Sustainable Development Goals, which have several targets on key diseases, including malaria, HIV, and TB. Looking at if you assess at every level and see the progress that has made, we can define it as a significant progress, but still it's not a satisfying progress, because still people are dying, still people are being infected and don't know what to do, where to go. Still there's a problem with affordability. There's still a lot of inequitable distribution of resources. Who gets what, who can do what, who can speak what, who can earn, who can take what kind of drug, what kind of drugs should be taken to this country and to this country in terms of their efficacy. Vaccines deployment, how much, what quantities should be taken to this country, what quantities should be taken to this country. We look at recent with the distribution of, let's say, a malaria vaccine for the under children under the age of 5, whereby there was a framework that was set to identify countries to which would be beneficiaries of this vaccine. I understand that is due to resources that are available, but I think in the next 90 months that have remained, we must understand that a person is a person, whether that person lives in Africa, whether that person lives in Asia, that person lives in America, lives in Europe, a person is a human being. And our life, the right to life is equal for everyone. So there's no need to decide or to set a framework who should get what, because what works better, everybody deserves to do it. We must build, instead of setting and complaining that we have low resources for diagnosing, treating, and preventing these diseases, then we have to struggle to ensure that we increase those resources. Because for me, I don't believe that the world does not have capacity to supply enough for TB detection. I don't believe that the world does not enough capacity to treat, to diagnose and treat all malaria cases and even HIV. So it's just a case of willingness and a case of intention, being intentional. So it is my call for the global community to be intentional enough to be to increase the political will, to increase even the scientific will, that we are going to develop these tools. We are going to innovate enough. We are going to integrate the tools that we have. We are going to modify and strengthen the tools that we have so that we are going to end these diseases. So it is a matter of commitment. It's a matter of intention. So we need to be intentional enough. And another thing that we need to do is increase the financial resources. And then again, this takes back to intention. There's a lot that is happening in the world, a lot of businesses that are happening. People need to deploy people, and most of these resources that we need in terms of the business, the global business, are coming from the low-resourced areas where TB infections are high. Last week, sadly, I lost a friend of my dad working in the mines due to TB, and this person had developed tuberculoma, that is the highest stage of the TB. And he died just because of, he was treated 4 years ago, then he thought it was over, but there was, I don't know, I cannot comment enough, but there was a lot of issues with the kind of diagnosis that he went through. And finally, he came to hospital when he's already severely sick, and he never thought it is TB again because he was earlier treated, until when he was lately diagnosed with tuberculoma and died 3 days later. So it is very painful to me to see such scenarios. While there is capacity, we have tools, we have science, people are discovering a lot of fun stuffs, but we need to put these fun discoveries into science for the people, science for the communities. And also, what we failed many years ago is, if you look at literatures, how science was being done, is the separation of science and the people, science and the community. We must do science for the people. There must be a responsible way of conducting science, in especially health sciences, must be conducted by involving the people, working with the people, because they know better, they know a lot, they know why they cannot do this, why they're not doing this, why they're suffering, why are they suffering from this. They know a lot. So that's very important for the next 90 days to ensure that there's effective mechanisms to engage the community effectively. And when I talk of the community, I'd like to reiterate this whenever I speak. Young people are the community. Young people are innovative enough to do this work. It is a must, it is imperative that young people are given space to think about these problems, because as you saw, if you read through the literatures, you'll see that the burden of diseases is just shifting, because the disease has killed so many elders. It's now finding its way to survive with us by affecting the largest of the population, and that is the young people. So it is very important that young people are considered fully as part of the community and engaged. But again, coming to this world of innovations and coming up with new techniques, it is important that the science community works together to integrate these approaches so that they are more powerful approaches. Yeah, that could be my great goal for the coming 90 days, but also investments are crucial. We cannot innovate, we cannot engage the community, we cannot improve research and development platforms if there's no financial resources on the table. So increase the resources, ensure that there is both this multilateral and bilateral funding platforms are fully capacitated to do the work, but also the both multilateral and bilateral platforms have to ensure that there is enough integrity fairness and social justice and equity in terms of distributing these resources, and but also monitoring and evaluation of these resources.
Yeah. Thank you. Thank you so much, Aloyce, again. And totally echo the, like social justice and equity should be the underlying principles. I also totally, echo all the recommendations which you have just said. And let us hope governments walk the talk on that, and especially on using the tools which we already have. There is no excuse to use outdated 140 years old tools when there are much better tools which can reach the people who are less served or underserved or unserved. And totally the hope lies in the young people, definitely. And we really hope that more leaders, more young leaders, join your force, which already are. You friends who have joined us late, we were listening to Aloyce Urassa, who is currently the chair of African Leaders Malaria Alliance Youth Advisory Council, a board member of Rotarians Against Malaria Global, and a Global Fund Advocate Network GFAN speaker. So thanks a lot, Aloyce, and it was really insightful to hear your words, and we really hope that your power can make a difference next month when heads of the governments meet at the UN high-level meeting on TB, as well as the SDG summit, which is happening on 18th September, if I remember correctly, and other important meetings which will be there as well, including pandemic preparedness. So all the best to you, all the power.